Good afternoon, everybody from Ann Arbor, Michigan. I'm Steve Ratner. I am the director of the Donia Human Rights Center at the University of Michigan. I'm also a professor at the University of Michigan Law School. And I'm very happy to welcome you to our second event of the fall on the topic of human rights, health, and COVID-19, exploring the connections. This is part of our event series that we have at the Donia Human Rights Center. This is a particularly exciting event, not only because of the topic, but because it's the first event that we're doing in partnership with the University of Michigan's Center for Global Health Equity, which is a new center at the university just endowed by last year and at the beginning of its mandate. So we're very happy, delighted to be co-sponsoring this event with them. My only role here as the director of the center is to introduce the moderator of this panel, so I'm very happy to do so. She is Professor Michelle Heisler of the University of Michigan School of Medicine, where she's a professor in the Department of Internal Medicine. Michelle, in addition to being a professor at the medical school, is also involved with the peer support care at the Michigan Center for Diabetes, and the health behavior and health education at the Michigan School of Public Health, where she's a professor in those capacities as well. And particularly important for this panel, she was recently appointed as the medical director of Physicians for Human Rights, which makes her uniquely qualified to be our moderator. And with that said, I'm happy to turn this event over to Michelle, who will introduce our speakers and explain the logistics of how it's going to work. So thanks very much and welcome, everyone.
Yes, thank you, Stephen, and good afternoon, everybody. And I'm impressed that so many people came right at 4. Our other discussants may not know that for years there was something called Michigan time, and nothing started until 10 minutes after the hour, and it's a very hard habit to break, I will confess. So I'm really, really delighted about this panel. We have a remarkable group of international human rights experts, public health experts, and we're really hoping, and again, we're hoping that the audience is not too large, because we really would like this to be interactive. I will moderate, but our panelists will talk among themselves. We will be eager for your questions. We know that we have a range of audience from undergrads, so we hope that we'll get you excited about this area and introduce you to some critically important principles, if you're not familiar with them, up to renowned experts in the field. So, so welcome, everybody. Today's panel, we will be talking together, exploring together human rights, health, and COVID-19, exploring the connections. And what we're going to do is I will introduce each of our participants in turn. They will open up with, they will set the table with just some opening comments and thoughts. And then I will get us started with just a couple of questions, and then we will be scanning. If you have a question, a comment, please do put it into the chat box. And we will have a discussion among us, and also be scanning the chat box so that we can introduce your questions, your comments, your views into the conversation. Unfortunately, we don't have the capacity to unmute in this webinar, but we hope you'll join in by sharing your comments on the chat box. So first, I think we'll start with, it actually works out that I'm introducing them alphabetically to give their opening remarks before we start the discussion. So I'm thrilled to introduce Chris Beyer. Chris Beyer is the Desmond Tutu Professor of Public Health and Human Rights. Just what an amazing name for an endowed chair at the Johns Hopkins Bloomberg School of Public Health. You actually know, I know you know personally, Desmond Tutu. He is director of the Hopkins Fogarty AIDS International Training and Research Program, and of the Center for Public Health and Human Rights, and he founded that center. He's an investigator for the Center for AIDS Research, an associate director of the Center for Global Health, He had been president of the International AIDS Society from 2014 to 2016. He's a member of the National Academy of Medicine and on their Human Rights Committee, and really pushing the National Academy of Medicine to increase engagement in human rights issues. Recently, he's also been consulting and doing a lot of work on efforts to preserve the scientific integrity of developing COVID-19 vaccines and ensuring their equitable public allocation. I do want to say he is just a greatly invaluable medical advisor. He's on Physicians for Human Rights Advisory Council, has led a number of important Physicians for Human Rights investigations. And so it's just a pleasure to introduce Chris to Dr. Beyer today.
Well, thanks so much, Michelle. And between you and I, Chris is fine. And it's really been, first of all, I want to congratulate you again on the PHR position and your leadership in Physicians for Human Rights. It's really wonderful for the organization. It's wonderful for all of us. So I'm delighted to be here today and learn more about both the Center for Global Health Equity and the Donia Human Rights Center. I think we all know and understand that this COVID-19 pandemic, the loss of life, the incredible toll on societies, families, the extraordinary emergence of inequality and inequity that has emerged has very quickly gone from an infectious disease pandemic to an enormous human and social challenge. And it has laid bare in society after society the social determinants of health and human rights and social justice issues that we often think are somehow not directly related to infectious diseases, but the connections are profound. And so I think it's very appropriate for us to be exploring together those connections. I want to start, and I'll just share one or two slides. I'm going to start screen sharing now to talk with you about one really important principle or set of principles. And I hope everybody can see that. And these are the Syracuse principles of 1984, which brought together human rights experts and public health experts under the auspices of the UN and WHO to think together and work through together limitations on human rights and civil liberties for public health goals and how those limitations really could be commensurate with fundamental human rights and civil liberties principles. And Syracuse has really helped us, I think through the kinds of restrictions that we're all living through with COVID-19, where they are commensurate, where they have been excessive, where they have been misused. And so I think it's important to explore that together. The first of the principles is that these kinds of restrictions, like mask wearing mandates, social distancing, the closure of schools, the closure of public events, need to be provided for and carried out in accordance with the law. Right? They need to be lawful and not unlawful. They need to be directed toward a legitimate objective of general interest. So in this case, the test has to be, are they helping to reduce spread of COVID-19? Are they being implemented in ways that do not discriminate against vulnerable groups and communities? Are they based in science such that they really have legitimacy, the legitimacy of public health? They should be imposed only for what is strictly necessary in a democratic society to achieve the objective. So this is a very important test, an important thing to think about, because we have had restrictions that really went beyond this, and they really can have important rights implications. We'll talk about some examples in a moment. They should be the least intrusive and restrictive to achieve the objective, right? So as minimally restrictive as we can be to achieve the public health goals. They should be based on scientific evidence and neither arbitrary nor discriminatory in application. This is extremely important. So I'll give you one very clear example of, unfortunately, from the United States. This current administration has limited and now stopped entirely the right to asylum, which is protected in international law, right? We're no longer allowing people to seek asylum, and has done so in the name of protecting the American people from COVID spread, when we are the country with the largest burden of infections, and as you all know, have suffered the most loss of lives among our citizens. Over 210,000 people have lost their lives in this country, and that's continuing. So limiting asylum seeking somehow to prevent people with COVID coming into the United States fails the public health objective. It's actually somewhat nonsensical as a public health objective. It is discriminatory, it is arbitrary, and it's not based on scientific evidence. So it fails that Syracuse principle. And finally, these should be of limited duration, only for as long as is necessary, respectful of human dignity, and subject to review. So these are the principles that we want to see. And now I'll just give you a few other examples of steps that governments have taken, and think to yourself, are they meeting the Syracuse principles? And just as an example, we had in Cambodia, the authoritarian government there arresting opposition leaders who were criticizing the government's response to COVID. So that is basically silencing the opposition. Does that meet the test of public health control when you are trying to control people sharing accurate information? And does putting anyone in detention for their beliefs and political activities meet that standard? I think not. So I would just like to say, and then I'll hand it back to Michelle, that as we think about what we want to talk about today, let's keep those Syracuse principles in mind. And I'll stop there. Thank you.
Great, thank you. Thank you, Chris. And next I would like to introduce, moving up. Yeah, so I'd like to introduce next Diane Desierto. She is a professor of human rights law and global affairs at the University of Notre Dame. Starting my video. Okay, here I am. So she is a professor of human rights law and global affairs at the University of Notre Dame. She's also a professor of international law and human rights at the Philippines Judicial Academy of the Supreme Court of the Philippines. She's active as well, along with her academic, her scholarly activities, as a lead and collaborating counsel in human rights and public interest related economic disputes in the Philippines and Southeast Asia. She has successfully litigated cases before the UN Human Rights Committee and the International Criminal Court, as well as the Philippine Supreme Court, among others. She's actually had a remarkable range of international appointments, including holding law faculty appointments at the University of Hawaii and Beijing University School of Transnational Law, as well as others, a number of France. As you can imagine, she speaks multiple languages. It's also relevant to this discussion that she is doing path-breaking work recently around establishing the right to development, with a focus on the need for vulnerable populations to be recognized by international economic dispute systems, as well as a great deal of expertise in the right to health, the right to life. So, welcome, Dr. Desierto, Professor Desierto.
Thank you very much, Dr. Heisler, and my thanks in particular to Professor Ratner for the invitation. I think of this as a virtual return to Michigan, having had the privilege to do my postdoc at Ann Arbor about close to a decade ago. I very much appreciate Professor Bayer's discussion on the Syracuse principles. My task today is to talk about a dimension about the right to health that is often not elaborated upon in the course of discussions on how to defeat or how to address or respond to COVID-19. And this goes back to the formulation of the right to health, not according to the World Health Organization Constitution, but rather according to the International Covenant on Economic, Social, Cultural Rights, where Article 12 of this covenant, this treaty that has about 162 states parties to this treaty, refers to the right to the enjoyment of the highest attainable standard of physical and mental health. There's an interrelatedness between the right to health with all other economic, social, cultural rights, which makes this discussion particularly timely because we're seeing a convergence of governmental actions, private sector actions, community actions that all traverse different aspects of economic, social, cultural rights and introduce their own differentiated levels of complexity. But one thing that should be clear is that we cannot look at the right to health in isolation or separate from all other covenant rights. This is why in General Comment 14, the Committee on Economic, Social, Cultural Rights emphasized at the outset that the right to the highest attainable standard of physical and mental health entails a close relationship and dependence upon the realization of all other human rights, particularly the rights to food, to housing, to work, to education, life, human dignity, non-discrimination, equality, prohibition against torture, privacy, access to information, freedoms of association, assembly, and movement, among others. Health is not defined the way the World Health Organization Constitution defines it, which limits it to the complete physical, mental, and social well-being of persons and not merely the absence of disease or infirmity. The third committee of the United Nations General Assembly, in drafting the Covenant on Economic, Social, Cultural Rights, embraced a wide range of socioeconomic factors and underlying determinants of health that include nutrition, housing, the access to safe and potable water and adequate sanitation, safe and healthy working conditions, and a healthy environment. Thus, when they elaborate the right to health, it's not about the right to be healthy. What it does mean is it entails certain freedoms, such as control over one's health and body, and the right to be free from interference with respect to protecting that health, and entitlements, such as to a system of health protection that provides the equality of opportunity for people to enjoy that highest attainable level of health. Now, the UN also recognizes in this treaty that highest attainable standard of health takes into account not just the individual's biological condition and socioeconomic preconditions, but also a state's available resources. This bears on the issue of one's right to the enjoyment of facilities, goods, services, and conditions that are necessary to realize the highest attainable standard of health. But most importantly, what is emphasized here and what has been lacking somewhat in different contours throughout what we've been seeing in the international system is that the right to health requires the participation of the population in all health-related decision-making, whether at the community, national, and international levels. That participation is necessary in order to exercise oversight with respect to the essential elements of health, the criteria of which were also set by the committee. The availability, first and foremost, of facilities, goods, services that depend on the state's development level. The accessibility of health services. Are they available on a non-discriminatory basis? Are they physically accessible? Are they economically accessible or affordable? Is there information pertaining to one's health decision-making that is accessible to the public? Is it also acceptable, not just for cultural appropriateness, but also in terms of scientific acceptability and medical ethics? And finally, in terms of quality, is it scientifically and medically appropriate? This right to health is not limited to a state's obligation in relation to individuals, but also extends to individuals, to states' obligations of duties of international cooperation to help realize the right to the highest attainable standard of health. Especially, no population should ever be deprived of the means of its own assistance, and duties of cooperation are well entrenched in the International Covenant on Economic, Social, Cultural Rights. What we should start thinking about, or at least continue to think about, is how there are differentiated capacities throughout the world with respect to responding to the COVID-19 challenges and the right to achieve the highest attainable standard of physical and mental health. In the Global Multidimensional Poverty Index for 2019, 1.3 billion people in the world are considered to be multidimensionally poor, meaning that they experience poverty in terms of health through nutrition and child mortality, in terms of education, years of schooling and attendance, standard of living, even when it comes to basic essentials such as water, electricity, housing, and other assets. With that degree of inequality and resource disparity for countries throughout the world, what is unfortunately missing in the debates regarding COVID-19 responses is an appropriate differentiated understanding of how there are more countries who've experienced the deprivations of the right to the highest attainable standard of health more than others. And in these countries which lack the capacity, there is a specific international obligation and duty of cooperation and solidarity that was legally consented to by states under the Covenant on Economic, Social, Cultural Rights. In November, the United Nations Open-Ended Working Group, which I have assisted on the right to development, begins its deliberations on the draft declaration on the right to development. And there, we also made explicit that the right to development includes development that is premised on the realization of all human rights and fundamental freedoms. One cannot think, therefore, of just the right to health in isolation from a prism of simply what pertains to the well-being of individuals or the risk assessments made by governments on behalf of individuals, but for a well-rounded understanding of how those decisions can be made safely, with autonomy, and with human dignity, consistent with the expectations of the right to the highest attainable standard of physical and mental health under international human rights law. I'll stop here and turn over back to Michelle, and perhaps you can continue the discussion after.
Wonderful. Yes, thank you very much. And a lot there to unpack and to talk about in the discussion. So I would next am very honored to introduce you to Esther Kizmoudi. She is an international human rights lawyer on sexual and reproductive health law, policy and research. She is chief executive of Sexual and Reproductive Health Matters, and she is currently a visiting fellow at Yale Law School, having more recently also been a visiting fellow at Harvard Law School. She brings a remarkable range and depth of scholarly and public service expertise to this discussion. She worked as a human rights advisor at the World Health Organization at their Department of Reproductive Health and Research for 10 years. And in that role, she contributed to the work of United Nations treaty monitoring bodies, the Human Rights Council, United Nations Special Rapporteurs, and regional and national legislative and human rights bodies. For the past 15 years, her work has focused on developing ways in which legal and policy development, health programs, and research can be shaped to improve the respect, protection, and fulfillment of human rights laws and the achievement of sexual and reproductive health. Her present work includes contributing to the reclassification of gender expression and other sexually related, gender-related matters, including the WHO ICD-11 International Classification Diseases process, critically important as we think that they know there are quite a few clinicians in the audience too, in particular related to legal, policy, and human rights matters. I will note that she is joining us from Geneva, and I know for many of you undergrads and graduate students in the audience, 10:30 is not a big deal, but for some of the rest of us, we're thrilled that she's joining us at 10:30 at night in Geneva.
Thank you so much, Michelle, and it's really a great pleasure to be in this panel. I would like to give some examples from the sexual and reproductive health and rights field that has been really active in the past couple of months, documenting the impact and possible solutions in relation to upholding sexual and reproductive health and rights in the COVID crisis. the sexual and reproductive health and rights community got used to. It's our reality that rights and health issues are being restricted, but the COVID-19 response demonstrated a very different challenge. And when the Human Rights Committee issued a statement on the 24th of April in connection to the limitation of the, in relation to the Syracuse principles, as Chris mentioned, we started to investigate the public health documentations really in the context of rights and the Syracuse principles as well. That was a very helpful exercise in understanding the depth of rights and sexual and reproductive health and rights in this context. And just going deeper on the issues that Chris and Diane already explored, I would like to give 3 examples that at the beginning, around April, we had a lot of estimates and documentation. Now in October, 6 months after the the outbreak of restrictive measures, we have more data and evidence that shows what worked, what doesn't work, what is a human rights violation, and what is the impact on public health. So going to the necessity to use least intrusive measures, now the evidence from investigating the impact of the lockdown measures showed that high quality contraception, abortion, and post-abortion care services were forced to close down due to strict lockdowns in many parts of the world, and were operating on reduced hours. Mobile outreach teams who primarily deliver contraception in remote, rural, or underserved urban locations have been suspended in several countries with detrimental impact in the most vulnerable populations. I also have to mention that on the health, we talk a lot about a health force and what health workers are facing in these measures, in this context. And there is a documented increased stigma and discrimination, stigma towards and discrimination against healthcare providers and against clients who made measures to provide sexual and reproductive health services in the context of restrictive measures. So it's not only against the clients and the general population, but also against health workers. In terms of investigating the least intrusive measures, we also found it very helpful to show that if it's not the least intrusive measure, closing all sexual and reproductive health services, basically, except probably maternal health services in many countries, what are the alternatives? And now we have documentation from many countries, and there is a brilliant paper in SRHM COVID-19 issue from Catherine Church and colleagues from MSI, that good practices from various countries show that states could facilitate self-managed medical abortion, emergency contraception via telemedicine, by waiving requirements that entail 1 or more clinic visits, including mandatory waiting periods, providing telemedicine counseling and mail delivery of abortion and contraceptive medications, and removing or suspending criminal penalties for self-managed abortion and other interventions. So investigating the least intrusive measure in the context of violations is not the only way of investigating this measure, but from a public health perspective, it's also very important to point out that what is possible. And we feel that it's really important in the context that we are going to the 2nd wave, or some countries to the 3rd wave, and we need to learn what kind of responses we wish to introduce in the upcoming context. When it comes to proportionality, and we will talk probably later about this, we show that the measures that have been taken, especially for complete deprivation of the population from sexual and reproductive health services, for example, an abortion that is a time-sensitive service posing improportional health risk on the population, and subjecting women and especially adolescent girls to unsafe abortion and other health risks. Examining the arbitrary and discriminatory nature of state actions, the current experience shows that restrictive measures often carried out in an arbitrary non-evidence-based manner are clearly discriminatory against women and girls, women living with disability, transgender people, sex workers, people living with HIV, and who face particular difficulties in this situation. It's very interesting to investigate the legal environment and how we're advocating for rights in the legal context, decriminalization measures, for example. And just to use the example of sex workers, it's clearly introducing curfews and mobility really took away the breadwinning from sex workers, and countries when sex workers are criminalized and now don't have access to work, they are bearing very significant consequences. There are positive measures, for example, in countries, and I would take the place where I live, Geneva in Switzerland, when sex work is recognized. There are absolutely phenomenal measures of, for example, recognizing unemployment for sex workers and providing benefits in this context. So alternative measures exist. I would like to reflect a little bit on the politics of COVID-19 and its implication on health and rights as my second point. We experienced that the responses to the pandemic in both high-income and low-income countries are embedded within domestic politics. And the countries at all income levels experiencing COVID-19 outbreaks have implemented lockdowns, and there is a huge politics about what essential services are. And as I mentioned, the excluding certain sexual and reproductive health services such as abortion, in vitro fertilization, but even cervical cancer treatment, condom use, or access to condom or contraception is perpetuating deeply rooted political and ideological rifts about sex, reproduction, and sexualities. And the denial of these services resulted in serious health outcomes. And I would really recommend those who are attending this seminar to look at our journal, because the evidence that is showing the discriminatory effects is overwhelming. I also would like to mention about the politics, and Chris kind of touched upon this, that governments introducing political measures is really overstepping many governments their emergency preparedness actions and using their ideology-based politics against marginalized populations, based on racial and sexual diversity, for example, to justify arbitrary measures and curtail civil and political rights that is really not falling under the scope of emergency preparedness that COVID-19 exposes. One of the examples, for example, Hungary, who has been acting in emergency preparedness, and the parliament and the government was allowed to take legislative measures. They also used to curtail transgender rights in terms of legal gender recognition that had nothing to do with COVID-19. So the crisis can foment change both for good and for ill. And as old ways of working are reconfigured, we feel it's important to proactively take this opportunity to protect the gains that have been made and develop new ways to move towards greater accountability for equitable realization of health, the right to health, and sexual and reproductive health and rights in particular as well. So back to you, Michelle.
And I'll unmute. Yes, well, thank you. These were really provocative and a great foundation for discussion. And each of you have given really striking examples of the misuse of the excuse of COVID-19 to restrict rights. I mean, certainly along with completely eliminating the right to asylum, eliminating basically the right to cross the southern to US borders for asylum seekers. In the US as well, there's been an effort to say that, oh, well, we're going to use COVID as an excuse to not give women access to abortions. So that's been happening in a number of states where the excuse of COVID has been to restrict reproductive rights, as well as this whole very polarized debate in the US about the extent of lockdowns. Here in the state of Michigan, actually, our Supreme Court just basically blocked the state emergency powers, as saying that it was not in the realm of the executive, but in the realm of the legislature to do that. So this question of least intrusive methods embedded in the Syracuse principles, this question of what's proportionate, what is a proportionate response, and each of you gave some examples of what would be considered a least intrusive means, what would be proportionate, but how do we define that? And I would love to push each of you to thinking about, from each of your perspectives and each of your areas of expertise, how should we determine what is proportionate in balancing, certainly the dangers of excessive shutdowns, using public emergency as a way to restrict rights, as well as the need to protect public health. So Chris, you first introduced us to the Syracuse principles. Why don't you get started, and then Esther and Diane, please join in and just help us think through how do we determine this?
Well, maybe one way to start is to think of a good positive example. So a positive example is, we have learned from the science that this is really fundamentally a respiratory pathogen, right? And that it spreads both through droplets and now clearly also through aerosols. And that many of the issues that we were so concerned about with sterilizing surfaces are probably less important. It really is a respiratory virus. And that the benefits of mask wearing, particularly when people are going to be in public spaces and in crowded spaces, are significant, and are not just significant for the altruistic motivation of reducing spread to others, but have another important element, which we have published on, Monica Gandhi, myself, Eric Gooseby recently, which is that if you do have an exposure and you're masked, you have a reduced, maybe not to zero, but a lower dose of exposure, and you are more likely to have an asymptomatic infection, which is a good outcome. So mandating mask wearing, for example, on public transportation, which the CDC tried to do, I would say is proportionate, right? This is a respiratory virus. Mask wearing, except for infants and a few people with a few rare conditions, is not harmful. It is, nobody loves it, but it is well tolerated, right? You are not restricting people's ability to get to work or to see each other, to go shopping, to get food, to do the things that we need to do, but you are reducing everybody's exposure. So that seems like a very proportionate response, right? The lockdown curfew issues, where people were mandated to stay indoors, except for a very limited number of actions, which in some countries required special permissions, were implemented very quickly in many countries. And I'd give you two prominent examples of India and South Africa, without a recognition that there are all kinds of people, huge numbers, for example, of day laborers, who cannot do that without not working, and in many cases without not eating. So to ask someone to starve to death, to reduce public exposure and movement, is not proportionate, right? The state has an obligation to figure out if you're going to restrict people's liberty in that way, you have to be able to supply them with food and water and some very basic minimums. China, of course, was very well known for having in Wuhan and then in other provinces imposed very severe restrictions, but also coming up with ways to ensure that people had adequate nutrition and water. So, you know, those kinds of restrictions without protections are not proportionate. And they proved, of course, eventually unenforceable. And tragically, South Africa ended up with the biggest epidemic in Africa, and India is about to surpass the US as having the largest epidemic in the world. So that's the other problem with these kinds of disproportionate responses. They're not sustainable, because if people have to choose between staying at home or not working and not eating and not drinking, they will vote with their feet, of course.
I mean, you really raised the important point of, in a way, there's the Syracuse principles and there's the right to health. And
Yeah.
Diane, say a little more, because it does seem that this is, in our earlier conversation, you talked about, you know, the rise of food insecurity and, you know, building on Chris's point that we worry about the public health dangers at the same time that people may be starving. And as you noted, especially in low and middle income countries where disproportionately people have no safety net against poverty.
Thank you for that, Michelle, and thank you for those points as well, Chris. When we talk about proportionality in regard to the right to the highest attainable standard of physical and mental health, we go back again to an exercise of differentiation. We cannot look at one universal prescription, such as a lockdown, and assume that the universal prescription of a lockdown will operate or play out in the same way across all countries that have different capacities. The classic example of Chris talking about India and South Africa, why did lockdowns work for some countries that started it earlier as opposed to countries that didn't, but later on were exacerbated? You find more and more infections, because when you look at the background capacities, there's a very high population density, there's an inability to socially distance. In some countries, social distance is a luxury. You can't imagine, maybe for the developed world, it's possible to just hunker into one's home and think about takeout and think about structuring education and work through virtual channels. For many parts of the developing world, those are luxuries and they are not the baseline. So when a lockdown is imposed on top of existing inequalities that are already being suffered by countries that do not have sufficient housing infrastructure, that do not have safe water, potable water, that do not have safe environmental conditions or safe working and health conditions, a lockdown is a guarantee of failure. This is why I appreciated that the World Health Organization Special Envoy walked back from this prescription a few days ago and said, it should not be the primary resort. Indeed, it should not be, because every country's national, regional, and community health profile differs capacity to capacity. And what's necessary to come up with a proportional response is in the first instance to have a baseline of what those capacities are. And unfortunately, many countries took advantage, and especially authoritarian regimes took advantage of the fact that, yes, you have license to impose authoritarian regimes, control who will come in or not come into the country, much less impose surveillance. This was also a time when the most numbers of human rights defenders have been shot and killed. Not for nothing, some of them supposedly because of breaking quarantine regulations, all in the guise of public health. So for sure, when we talk about proportionality, we have to look at it relative to the objective, but also relative to the inherent capacity that individual states and populations have.
And Esther, you gave some really compelling examples of arbitrary, discriminatory, and too intrusive, disproportionate responses. One thing you noted is that we have learned from the prior lockdowns We've learned about how much harm has happened, including one other related to sexual and gender rights is the just overwhelming increase in domestic violence and the vulnerability of many women who were locked down with their abusers. So as you think about the lessons from the prior lockdowns and thinking about this question of proportionality, what to you are some of the key as you think about sexual gender rights, reproductive rights, and health, including violence? What to you are some of the key lessons as we face another wave of increased infection and have to think about the appropriate response to that?
I think what is really fundamental here, that how to think about proportionality in the context of health. So there are restrictive measures restricting civil, political, socioeconomic rights to protect health. And from the sexual and reproductive health perspective, we are restricting sexual and reproductive health services that are causing harm to health. So how it is proportionally? Are we measuring it with numbers on morbidity and mortality? Or we are figuring out that health is a complex phenomena, including respiratory issues and including sexual and reproductive health issues. So when we see the harm in relation of mental and physical health because of violence against women or other issues, we need to ask the question that how complex the protection of health is and how the restrictive measures are balancing out health protection vis-a-vis one disease and other health protective measures. It would be very interesting to hear Chris' opinion about this, that can health just be measured and restrictive measure justified to only protect only one aspect of health. The other issue is that how this proportionality intersects with non-discrimination and marginalization. And we have a very interesting paper, and Chris and Diane is also mentioned that, for example, if we look at urban slums, in some countries, like 30, 40, 50% of the population in a given city, like for example in Chennai, in India, is 30% of the population lives in urban slums and half of the populations are female. COVID-19 poses a disproportionate health risk of women in reproductive ages, and not only because of health issues, but also because of economic, environmental, and social political issues. So we have the facts that from the respiratory disease perspective, it affects men more in a higher number. But if we look at the risk factors that the restrictive measures are imposing on women, we see that women are exposed to a much higher risk factors. And if we take, for example, just access to water in these slum areas, all the population in these slum areas are facing hygiene issues because of restriction to water, when water should be one of the measures that we need for prevention measures for COVID. But if you look at women and girls in terms of how they are affected by lack of water in menstrual hygiene, in terms of protection against violence women that is not against women that is not connected to water, but in general, it's just disproportionate how social services are closed, sexual and reproductive health services are closed, shelters are closed. And the good news is, and I think I really hope that governments are looking and states and other actors are looking at the positive examples, because we have fantastic examples when sexual and reproductive health services, for example, including IVF, cervical cancer, for example, in Lebanon, was never closed. And they managed. They live with a high number of refugee population. They are facing all kinds of crises, but managed to balance out proportionally restrictive measures with protection of other health issues, such as sexual and reproductive health issues as well.
So any other comments on this, Chris or Diane? Any reactions or yeah?
Yeah. I mean, I think you're absolutely right, Esther. And it, you're of course focusing quite rightly on the gender issues and reproductive health and rights. There are many other domains that also have been very negatively affected. So we've seen, for example, big problems with childhood immunizations, right? Globally, and kids falling off immunization schedules. In general, what has happened with the restriction on health services broadly has been that everything that was perceived to be elective, which is another way of saying preventive, could be put off because of the crisis, right? And so we saw, for example, a lot of work and creativity in the HIV space that I'm very familiar with to try and ensure there were no treatment interruptions for people living with AIDS, living with HIV. So that is important and fantastic. But on the prevention side, which is the testing and PrEP and access to STI services, that just went off a cliff. So you see the reproductive issues also, again, contraception perceived to be elective, perceived to be preventive, and not absolutely fundamental to the health and well-being of women and their children and families. And we thought we were now going to be involved in this period of catch up on all of these elective procedures, but we're not out of this epidemic yet. And we're having second and third waves. We have, more than, I think now it's more than 30 states that have increasing rates again in the United States. It's very clear that we are likely to be coming into another wave. And we really have to figure out that balance of addressing fundamental. I mean, childhood immunization is not elective. We shouldn't see it as an elective procedure, right? It is fundamental to the health and well-being of children, who are much more likely to die if we have measles outbreaks than they appear to be from COVID, right? And, that is just a reality.
Michelle, if I may add, perhaps on vulnerabilities as well, I have not yet seen a national COVID response plan from any of those that were submitted for monitoring to the United Nations that specifically targeted the most vulnerable, especially communities of color and indigenous peoples. What we see is a platform of responses directed towards flattening the curve, but without disaggregating the curve. The curve might well be steeper and higher when it comes to communities that historically do not have good quality health care or access to sufficient facilities for healthcare to deal with a pandemic apart from other pre-existing conditions. So even in the national policy planning level, whether it's China or the United States or Vietnam or Taiwan, any of these countries that have rolled out national plans to address COVID, none of these plans have actually specifically targeted vulnerable populations or have identified what they will do for communities of color, for indigenous people, for those segments in particular who face intersectional challenges from human rights deprivations that already exist. And that's a problem, because even in the right to health, the planning for national action plans are supposed to take that differentiation into account. And we're still not seeing it 8 months into this pandemic.
I mean, this is perhaps an unfair follow-up question to international human rights lawyers. Chris, you're a public health expert, but I mean, I would love to hear a little bit of thinking about what would that look like? What would a plan, and maybe that, we don't have too much time left, and maybe that this is a good point to say, what would a vision be for, what would a plan be that, we've recognized that this has had devastating effects on the most vulnerable, and in terms of infection, in terms of death from COVID-19, and in terms of other restrictions, not being able to get abortions, not being able to get food, not, all the other ways that people have suffered and become ill and died from, not even if directly from the virus itself. So, yeah, so what would that plan look like? You guys as you guys have looked at this, from each of your perspectives, what would you like to see as a national response? And again, Diane, you've focused a lot on the right of intercooperation. I mean, the importance of international cooperation in order to actually effect the right to health, the right to development. So yeah, what should we be looking for? What should we be advocating for to achieve what you're saying you're not seeing, that is not there in these national plans?
Should I follow up? Okay, if I may. I mean, what's also missing and what we haven't seen, what I would love to see, is that as policies are being rolled out, whether at the public health community level or at the state level or at the national level, not only that information is accessible to everybody, but every individual, every citizen, every person who's affected by this pandemic actually does have a real voice in the matter, other than the deluge of the information that's being blasted their way by public health officials. We're not seeing a lot of that because we're also not enabling, without that participation, we're not enabling mobilization, especially in a time of pandemic when people are locked down and are quite unaware of what's happening to medical capacities, to resources, how states are deciding to apportion or allocate resources. It's very difficult at this time to mobilize in the traditional sense of mobilizing. So without that, there's no real meaningful participation when it comes to policy planning, short, medium, and long-term, on the right to health, especially in the backdrop of addressing COVID responses. I mean, there's that. There's also other matters that we could discuss, especially when we talk about accountability later. But for now, I'll turn over to Chris or Esther, who might have other views as well.
Maybe I just follow on the participation, and I think there are some great examples that actually doesn't work without participation. So, and I think that it's just basically shows that without discussing with affected communities and vulnerable communities about their needs and rights, you cannot have a proper planning. So just to give a snapshot of an example, I think there's a positive example again, published in our journal about Kenya and maternal health response, that many women don't have timely access to maternal health services. So they realized that addressing the movement, that the movement restrictions, even posing a higher risk on vulnerable population, especially poor women, rural women, urban slum women, of not accessing services. So as a positive measure, they established a system when pregnant women in labor during curfew hours can call the local administrators, who can then link them with licensed motorbike taxis, so that the initiative offers free medical advice and transportation services during curfew hours. But they documented that there was an increased maternal mortality among poor urban slum women, and they tried to look at what the problem was. And it's simply that the taxi driver didn't want to go to those areas because they considered to be dangerous. But it took 4 months to figure out that actually this measure doesn't work without including the women and asking them that how they can actually have what measures work them. And now there is a parliamentary inquiry that is looking for resource allocation, how to address increased maternal mortality in this area. That leads to another point, that it really has to be, we are just this basically a boring slogan for us, that it has to be a multi-stakeholder process, because you need the health expertise, you need the Ministry of Finance, but you also need, I think we need to reconstruct our remedial mechanism, because we are in an emergency stage, and we learn what works, what doesn't work. And in many countries, the justice system and the remedial system just completely shut down. And I think democratic societies, however we call democratic societies, they cannot work without remedial systems. So I think it goes back to the proportionality. Is it proportional in such a crisis like COVID-19 to completely shut down our access to remedy and remedial system? And one more point, what we are also learning from the donor community, and we are in conversation with the donor community, that we need greater reflexivity. And donors and others from high income settings need to be more flexible of reorienting funding, responding to the needs of most marginalized. And for example, participatory grant making is also a very important measure for microfunds and others, and building solidarity. And the good examples are also coming from those settings when we can experience the creation of alliances among those working in the primary healthcare, universal healthcare, and bolstering, for example, regulations between private sector and public sector regulations to be able to increase universal health coverage. So I think we are talking, for example, about universal health coverage, but now it's the action point that actually we can do it now and show and demonstrate how it can work, for example, between the public and private sector to eliminate discrimination and improve universal healthcare.
Wonderful.
Well, I think if I might just add, and maybe take it down to a very local example, certainly one of the core principles of a rights-based response, of a human rights-based response, is that in human rights, we are always paying attention to who is marginalized, who is excluded, who are the least likely to benefit from whatever interventions are, and making sure that they are not left behind, that they are not excluded, right? So in the early phases of our COVID response, we had, of course, in the US, a scarcity of testing. We had a big problem with the first round of tests from the CDC, and the state of Maryland made a big effort to try and get testing going and set up testing facilities. And here in Baltimore, they were set up mostly as a drive-by mobile testing sites in parking lots. Well, to use a drive-by mobile test site, you kind of need a car, right? And we were not encouraging people to use taxis or Uber. And it turns out that these were mostly placed in higher income neighborhoods where parking lots are, where people felt safe and secure. And there was a huge desert of testing capacity in our two lowest income neighborhoods, East and West Baltimore, and where there is the densest housing, where there's the most crowding, where there's the most intergenerational living, where there's the lowest level of health coverage and health insurance, and where the majority of people don't have white-collar jobs and have to move around. So not surprisingly, these very quickly became the highest burden areas in the city for COVID and where there was the least testing. And we actually had, in the first few weeks of it, a person walked on foot to one of these mobile drive-by testing centers and said, I would like to get tested. And they made him stand in line with other cars as though he was a car, because they just didn't have sort of the imagination to understand that some people don't have private cars. So that to me is an example of what a non-rights-based approach ends up yielding for you, because you are coming at it from your lens. Well, of course, we need a place where people can drive by. We need parking. We need it to be in a secure area. No, you need it to be where the people who are most vulnerable to this epidemic are, and it needs to be accessible to them and useful to them, right? And amazingly enough, or tragically, I should say, within a few months, these areas turned out no longer to be the most affected populations in the city. That moved to another zip code, which also was something of a testing desert. But this is where the majority population is Latinx and undocumented migrants. And they now are the group who are most disproportionately burdened. again, because of occupational exposures, multi-group housing, and having no access to healthcare. So a rights-based approach would have, immediately not excluded those people, but prioritized them, right, for services.
If I could follow up on the access to healthcare, because especially we talk a lot about access to healthcare, but we do have to think about how much more difficult access is when we are talking about the global South. And I say this in the context of the looming vaccines or the looming treatments that are being touted from the developed world, primarily, where most of the pharmaceuticals are. And the challenge is this, and we know from past experiences that the developing world, absent any purposeful international cooperation mechanism or institutional aid that will come in, will not be the first to receive the vaccines. It will be served first and foremost out of self-interest to the countries where these pharmaceuticals are located. There will be affordability issues because of demand. When the World Health Organization tried to set up the COVAX facility, everybody joined except the countries that are producing or in the process of producing vaccines. So even as we speak, there is a looming emergency, and it has been there already for the last 15 years, 20 years in the global South. And I'm saying that in quotes because the global South is very well differentiated between the least developed countries, the middle income countries, all of which have very different profiles. I come from the Philippines where right now there is no hospital bed available. They're at max capacity. It's even worse in the rural areas. But there is no aid that is forthcoming. And there is no dialogue taking place at the international, the multilateral level to get this going, because there already is a lag, and yet countries are not coming together at this time to try and address that looming crisis. I mean, in a Washington Post article a few weeks ago, there was a massive feature on Native Americans who were most hit by COVID-19 and who are steadily dying off. Did we see any proportional governmental response? We didn't. And that's the kind of indifference that we're facing today. I mean, if we're looking at accountability, for me, participation is one dimension of it. Remedial access, as Esther was talking about, is also important. But apart from that, at the international level, all states really do have to take their obligations seriously. And if necessary, let's start exploring our avenues for enforcing the Covenant on Economic, Social, Cultural Rights. The International Court of Justice is already litigating cases involving this very same human rights treaty. Maybe it's might be the first to get states to cooperate and to enforce those obligations to cooperate.
That's a great point. I want to start addressing some of the really excellent questions that have been coming in. And I apologize. I was looking at the chat for the questions, and I appreciate that Professor Ratner alerted me that I should be looking in the separate Q&A box. So we do have some questions. We actually have a kind of foundational question that I think a number of people in the audience may be wondering about. And this is from Ambassador Susan Page, who asks, so are there any enforceability provisions, first for the Syracuse principles? Like, how do we think about accountability? As you guys have started to discuss, how do we achieve accountability? And also, Diane, you touched on this, but when you think of the International Covenant of Economic, Social, and Cultural Rights, what mechanisms exist to hold states accountable to breaches in among those who have ratified it? And especially, Ambassador Page notes, when many member states' highest courts uphold these violations as being reasonable. So yeah, tell us a little bit, what should we be pushing for as we think about accountability and mechanisms to enforce these? So I don't know, who wants to tackle the Syracuse principles?
I'm no lawyer, but I will say that Syracuse is a set of principles for grappling with these issues, not truly for adjudicating them, and it does not have an enforcement mechanism.
I would add to enforceability we have to conceptualize of enforceability at many levels. There's legal enforceability, there's political enforceability. So even at the United Nations, we think about how we enforce human rights treaties. They could be done at the local level in countries that internalize human rights treaties directly. You can sue on the basis of those same treaty provisions or on the basis of legislation that implements those treaties. We should already start thinking about that as well. But that's at the level of litigation, which is an avenue that is open, but it's also possible, perhaps, under the Inter-American system that has a very broad reading of the right to health. One can start looking at the Inter-American Court of Human Rights, possibly the European Court of Human Rights, the regional human rights systems, the African Court of Human Rights. But that's legal enforceability. We're talking about what really, apart from, and that's going to take a while given fact-finding, what kind of enforceability will make countries act now? And I'm thinking about the kind of cooperation and coalition building that it took to get members of the World Trade Organization to waive compulsory licensing requirements so that medicines, in particular for HIV and AIDS, could be replicated and made available, publicly available to the countries that need it the most. This is one such moment where we need that kind of coalition building again, that kind of mobilization across the board, which is so difficult when most of us in the world are in lockdown, but we need this kind of mobilization now to get countries to waive, even when it comes to not just vaccines, but even the trade of PPEs, which is harder to access for many developing countries, very easy to access for developed countries. We have to start those conversations at the political level, whether at the level of the multilateral system at the United Nations and international civil society, or even before our own governments and our own constituencies. But at some point, that political enforceability will get us moving faster than, I would say, a litigation at a time of emergency when courts are in slowdown as well.
Mm-hmm. Yeah.
I still, I mean, I'm very much an idealist, and I also want to believe in some of those cases when actually national legal mechanisms, even legal mechanisms, are working in some countries, when there is a trust in the national court system, in the human rights system, and actually unusual measures are taken to the court in an emergency manner to say whether a lockdown of, for example, and it worked in some countries, but even in the US it worked, to challenge the lockdown of abortion services, for example, or challenging some other, like closing of certain services, or even mobility measures. I think it's also very important that those mechanisms are empowered with information. So if you look at, for example, parliamentary committees and what constitutes, we are in this consortium then when we revitalize the understanding of rights and evidence-based knowledge. So how knowledge is out there that is evidence-based and rights-based and not ideology-based, and how are we empowering our remedial mechanisms, whether it's an ombudsman system, it's a parliamentary inquiry mechanism, it's other mechanisms that actually the health information is out there, to enable those bodies to make informed decisions around that. And I believe that 6 months ago, we didn't have as much information and data that we have now. So I would also put a little bit more faith on our own national remedial mechanism. Of course, it's not working everywhere, but revitalize our imagination, how we want to actually challenge these restrictive measures and not just to accept it.
Wonderful. So, and this, thinking of information, accountability, I have a question from Christian Casanova, who is a dual degree student in health informatics and public policy. And you've talked about the importance of transparent information and remediation. And Christian's question is, we know there's been an epidemic of misinformation. I think, as the Secretary General said, we have an epidemic, a viral epidemic, and an epidemic of misinformation and disinformation. And his question is, how has COVID-19 misinformation on symptoms, overall impact, how is that intersected with how this has been handled in countries, especially in countries that do have questionable human rights practices, weak health infrastructure, and also how are we going to go about combating this misinformation? That, you know, a huge amount of damage has been done, but how does this intersect with some of the issues and questions that you've been raising? I don't know who wants to go first on that. Whoever.
Well, I can jump in. So it's a very important question, and thank you for it. I think the first thing to say is that in a public health emergency, communications and dissemination of information is incredibly important. And we have had, in the US certainly, quite a good history of that. But the response to this pandemic has to be seen as a signal failure of public health communications. We have had leadership at the top coming from the White House contradicting science, apparently with full knowledge that this was contradictory to the evidence and the science. We've had confused and confusing messaging, and this has led to a terrible politicization of the basic aspects of public health, so that mask wearing, which is a very fundamental aspect of dealing with respiratory viruses, becomes a political badge, a political statement, and not a basic protection of all of us for each other. So I think that has been a huge failure, and it is in a profound way also a rights violation. And I'll just briefly say that one of the fundamental rights in the social, culture, and economic rights area is the right to benefit from the fruits of science, it's the right to benefit from the outcomes of science. And when science is bypassed, is demeaned, is ignored, is undermined by political leadership, all of our ability to benefit from the science is being withheld from us. And so that is a fundamental rights violation. I think it's one that the human rights community has probably insufficiently paid attention to. And particularly now, where we are living in this world truly in information societies, and where disinformation has played such an enormous role in undermining other rights and indeed in undermining democracy in so many places. And that's not a first world, third world, the low and middle income, upper income country. I mean, the misuse of Facebook by the junta, the military in Myanmar, led to a genocide. Or helped actually empower a genocide. So this is really a global phenomenon, and it's one that I think is going to be an enormous challenge for those of us who care about human rights and democracy.
If I can follow up on that, this is a very challenging area, the area of information and misinformation, and identifying which is which, in view of the information barrage that we get from a situation of relative lockdown, right? Where we're wholly dependent on the curated experience that we either get on social media or through journalistic reporting or through other avenues where we get our information. It's not like we can go out there, talk to our neighbors, talk to our public health officials. It's not the same kind of information ecosystem where we can do secondary validating or vetting of the information that we're getting. For the most part, most of us in the world who have the ability to access the internet, we're reading what we see on the internet. And from my standpoint, as a person who appreciates and values science, but also is not herself as an expert in science, it gets confusing when the CDC, for example, has multiple positions on the same subject, on what should be done and what should not be done. Is it airborne or is it not airborne? Or even when, I think was it a few days ago, there were 3 public health experts from Stanford, Oxford, and Harvard who came up with this declaration saying that we should have some sort of focused protection and allow those who are healthiest, focus on the most vulnerable and allow the healthiest to just try and reach herd immunity, which also stirs so much controversy because we're supposed to be listening to public health experts. So the challenge for me, as well as for many populations who are receiving information, is how do you validate the information? What about the circumstances when the scientific community, the medical community is also at loggerheads in the face of risk, in the face of all of these measures that are being put forward? In international law, we have a principle we call the precautionary principle. In the face of scientific uncertainty, you take the least harmful measure. You should favor the least harmful measure that will give the most possible effect to the human right concerned. But I can't underscore enough, the challenge to Christian Casanova's question is, the problem with human rights fact-finding at this time is precisely the very limits that are being placed on human rights fact-finding. The United Nations has not been able to send in any of its inspectors, any of its expert teams to all of these countries, which have decided that they're going to take a very parochial approach. And indeed, if there's no initial sharing of information, there's going to be some frustration. I recall when Taiwan said, how come the UN doesn't want to take our information and our experience early on in this pandemic, just because we're not a member state under the United Nations, a member of the United Nations in this respect, a full, considered state member of the United Nations, doesn't mean that our experience is any less valid from a public health perspective. So I thank Christian for the question. I think what you highlight is the question of who's responsible and who's responsible for all of this information, how many or all of them who are responsible. That's an exercise in human rights fact-finding that will unfortunately not be undertaken in the middle of an emergency. But what I worry about is in the middle of an emergency with more and more human rights defenders being threatened and basically eliminated during this pandemic, the opportunities for monitoring this kind of information are going to narrow even more. So thank you for bringing the question. At least where information is concerned, that's something that's a massive deficit where the international system has not given us much focus.
Michelle, sorry.
Oh yes, I was just saying muted. Esther, would you like to add anything?
Yes, I would like to address another question, and I really wouldn't like to ignore the question that someone, and I don't see it now, someone said that talking about participation and vulnerable population, what about that this panel would include some of the members of the marginalized communities? And to be honest, I think it's a great difficulty to, in one webinar, to give a variety of opinions. I see these discussions, these global discussions, as a kind of continuum. And I see fantastic webinars when those that are focused with discussions with marginalized populations as well, and just bring some of the voices that very early on we had a discussion, we wanted to hear. We didn't have the evidence, but we wanted to hear the voice of marginalized populations. We had a fantastic speaker, Lizzie Kiyama, from the Disability Women with Disability community from Kenya, Mauro Cabral from Argentina, who is leading a global trans organization. And I just wanted to bring their voice, that how interesting it was. It was in April. And both of them said, very interestingly, from the disability and the trans community, that he's like, welcome in our world. We are living with restricted mobility from different perspectives, the disability community, because we don't have mobility. And for example, those living with physical disability, intellectual disability, for various reasons, we have limited access already. So at least you can experience now how we live. And the transgender community said that we are criminalized, pathologized, we don't have access to services, we don't have access to remedies. This is our world. Welcome in our world. And it was a very interesting reflection, actually, to see that from this perspective, how you want to challenge legal policy, health system responses, that it's really an exacerbation of vulnerabilities, and how we actually, these restrictive measures are addressing already existing deeply rooted measures as well in relation to marginalization and vulnerability. I just wanted to make sure that this comment is not dismissed, and I agree that we need more conversations with marginalized communities as well.
Yes, I also really appreciate that question. The question disappeared because I privately answered that we as organizers, need to be conscious of that. And, I think it is an important question and pushing us all. I know in our PHR webinars, we were organizing a panel on homelessness. And we invited a range of speakers. And one of the speakers who we asked said, I don't see any people of color on this panel. And I've made a pledge to myself that I'm not going to present on any panels that affect people that are where the people that are disproportionately affected by an issue are not represented. And I have to say, it was wonderful. She was a junior person, and she said, I'm not going to participate unless, I can give you some names of some good colleagues. So I think thank you. This was from Chinyere Neal, who's on faculty at the School of Public Health. So thank you for continuing to push us on this as we think about, representation and how we actually manifest that. This is such an amazing panel. We only have 5 more minutes, and I can't bear to ask another question and have it cut off. I do know that there's one student question that we didn't address. So we, yes, well, yeah, that's Joe Stephen Ratner's commenting, but let me just see. I know we had one question from Jenna Chami, and it's a pretty straightforward question. So I had so many other questions that we didn't get to. I should not be surprised, because this is such an incredible group of thinkers. And but let me make sure that we get our last student question from Jenna Chami, who is an MPH student. And this is a pretty straightforward question of just really trying to understand, we've talked a lot about the role of the UN, the WHO, national governments. And I think if I'm interpreting this question correctly, it's really saying what more could the UN and WHO be doing to kind of lay out precedences, best practices, to ensure that countries follow proper precautions during the pandemic and ensure that everyone receives equitable health care. So whoever wants, there's more that, and maybe Esther, that's not fair, but you worked for the WHO for 10 years. Of course, in the US, we're in a context where the US has absolutely withdrawn support. But as you think about the WHO, is there more, as you watch how the WHO is working, that the WHO could be doing to try to set a path of good practices?
Unfortunately, I cannot really respond. I'm not an expert on the COVID response particularly, and I think I'm a little bit biased because I'm really impressed how WHO came up with guidance and guidelines on sexual and reproductive health issues, for example, including on essential services, self-care, violence against women. That knowing how long these guidelines take, this guideline development usually takes 2 years, and these evidence-based guidance came out. I find it incredibly helpful, and I know that the implementation and FIGO, the Federation on Obstetric Gynecologists in Media implemented, and IPPF, these guidelines. So I'm a little bit biased from the sexual and reproductive health perspective that I think we have, and it's again the question of enforceability, and implementation, how do you bring it to countries? But maybe I pass the question to Chris and Diane in terms of the overall COVID response, in terms of the UN and WHO.
I think briefly, sorry, Chris.
Go ahead. No, go ahead.
I just thought, I think briefly, the United Nations, from the April address of the Secretary General to the follow-up plan of the High Commissioner for Human Rights, from the outset, they already said that the response to COVID has to be based on a human rights approach. And in fact, in the 1st of July, the Security Council called for a termination of hostilities, or at least a suspension of all hostilities everywhere in order to deal with COVID-19. That appeal, not necessarily a resolution that calls for compulsory behavior, but that appeal has largely fallen flat. I think the Security Council can do more. I think the General Assembly can do more. I certainly think that They have not opened up the channels for fact-finding, for the compulsory sharing of information and transparency of information on many of these responses to COVID-19. I'm seeing others construct an index, non-international civil society organizations construct an index on COVID-19 responses and their impacts on human rights. But it's surprising that's not even being attempted at the UN, much less to try and start a remedial process, but also a long-term human rights dialogue, centered dialogue on responses to COVID-19. I think the Security Council has been quite reticent, and that's probably also affected by the United States' own vacillating positions in the Security Council in this respect. There's more that could be done at the UN, stopping short of just deferring to the individual initiatives of states.
So I'll just say very briefly, you know, the pre-COVID period has been marked for a number of years by rising nationalism, a decline in international solidarity, an anti-immigrant movement in many, many countries, far-right populism, and irredentist nationalism. Those were all considered to be major concerns. There's nothing like a global pandemic to show you that we really are a small planet, highly interconnected, and have enormous responsibilities to and for each other. And so what you'd like to hope is that coming out of this, and inshallah, we will come out of it as a global community, that we're going to see some of the folly of those nationalist and you know, anti-immigrant, anti-solidarity movements. You know, this has happened before. Many people credit the beginning of the Renaissance with the Black Death and the beginning of the Enlightenment. So, you know, moving out of a kind of magical form of thinking into a much more rational one. So that's a very big picture answer, but I have to say we need global solidarity to defeat this pandemic. And of course, we haven't seen anywhere near enough of it.
Well, on the note of global solidarity, that's it. Well, as moving towards global solidarity, we'll leave out your last clause, Chris. We need and we will work for. But anyway, thank you so much. This is really been lively. Again, we touched the surface of so many fascinating areas, and just it's really been a privilege to have this group of really leading experts in key dimensions of all these areas that we've been focusing on. So thank you. I do want to tell the audience that Stephen Ratner has asked me to be sure to mention that the next event will be on November 12th. It will focus on cross-border migration, which Chris and I have touched on several times. It will feature Professor Tom Ferrer of the University of Denver, who has a new book about this. And then the Ford School's Professor Ann Lin will be presenting on that. And again, thank you for your questions from the audience. Thank you for your comments from the audience. And really, thank you to Chris, Diane, and Esther. And Esther, I hope you have a good remaining couple of hours of your night. Couple of however long the night lasts. You're in Geneva. You're about ready to have dinner, right? So anyway, thank you all.
Thank you.
Thanks.
Bye. Bye-bye.
Bye, everyone. Thank you.
Bye.